As the background has already made by Dr. Rajiv, and presume I presume that the oral semaglutide invention, I think particularly this technology, will be possibly the greatest innovation of the century. Because this will definitely pave the way for the oral insulin. Because this is the first, if you recall, even in the history of insulin of 100 years. Even in 1923, there was an attempt to make the oral insulin even at that time. But unfortunately, that could not be pursued for a longer time, and relentlessly failed. In fact, now in almost 100 years later, we are able to have this technology, and this technology really has paved the way for possible for oral insulin in future. So what I am talking about the GLP-1 agonistic antibodies. So we all talk about the GLP-1, but I think anyone can share with that why the GLP-1 levels are lower in diabetes. Only the one ethnic group in the world, that is only the Japanese population, the GLP-1 levels are lower, even in patients with type 2 diabetes. So the GLP-1 levels are lower in patients with type 2 diabetes, possibly because of the gastroparesis. They do have some element of gastroparesis, which might be contributing for that. And another reason, even people have now talked about the L cell glucotoxicity. Even the L cells, they do experience the undesirable effects of the glucotoxicity. That's why they are not able to secrete the GLP-1 in response to glucose. So that's why the GLP-1 levels are low in patients with type 2 diabetes, and makes a rationale for use. Safety, and there are so many trials. There were clinical pharmacology trials for this molecule. We have 24 trials. We have a phase 2 trial, that is for a dose determining studies, and phase 3A trial, that is basically RCTs with many other drugs. So total number of patients who have been enrolled in these trials is around 9,000 plus, and subjects exposed to oral semaglutide, something around 6,000 people have been exposed. So reasonably vast experience, vast clinical studies to say that the drug is effective and drug is safe. So these are the different trials, different ethnic groups, and you name any drug which we are using in the current armamentarium, it has been studied. So that makes us more bolder to use in clinical practice. So yes, first we talk about the change in hemoglobin. That's remains the most crucial. How does the reduces the hemoglobin A1C and to what extent? And the extent is up to 1.5%. If you see any study, even the sitagliptin, even they have compared the liraglutide, their own GLP-1 molecule, and however the dose of the liraglutide here is 1.8 milligram. So it is a variable from 0.7 to 1.5. So the maximum reduction in hemoglobin A1C you can have with this class of drug is around 1.5%. Remember, this is regardless of the weight reduction. So even you may not have a weight reduction, but you have a reduction in hemoglobin A1C. So does it mean, what does it mean? It means that the weight reduction and hemoglobin A1C reduction, they do not go hand in hand. So that's a different mechanistic insights into weight reduction and different mechanistic insights into the hemoglobin A1C reduction. The another important point is that why we would allow variability in a reduction in hemoglobin A1C from the same molecule with the same doses of 14 milligram, that is from 0.7 to 1.5, and the reason being that the population heterogeneity in the beta cell function. That's a very, very important which they do have. And in addition, the other important point is besides the duration of the disease, If the duration of a disease is a variable, the response rate to the reduction in hemoglobin A1C is also quite variable. So like we have our gliptins around 0.6%. This drug is around 1.5%, definitely higher, almost double, just like the metformin, but certainly more potent, but it is regardless of the weight. Then the change in hemoglobin A1C from baseline, those who had more than, so we all know that higher the baseline hemoglobin A1C, greater is the reduction. So reason for that, why the drug become more effective even in presence of this? The reason for that, why with a higher hemoglobin A1C, you have got a, because if you see the rate of a rise in hemoglobin A1C in first month, second month and third month, that is 50%, 30% and 20%. So what I mean to say is that, suppose someone has got a hemoglobin A1C of 11, your baseline is 7, so it is a 4% difference. How it has been built up? It is built up by 50, 30 and 20. How you lose it? You lose it by 20, 30 and 50. That's why if you have a higher hemoglobin A1C at baseline, you are going to have more reduction in. It is not that the drug has become more potent when the hemoglobin A1C is high. It is not. It is how the rate of decline or delta change in hemoglobin A1C which you have in time. If you go further, so overall, you can see that the last and the life. So across all the trials, those who had a hemoglobin A1C of more than 9%, it had a reduction of 2.6% as opposed to 1.5% overall. Those, how many could achieve the hemoglobin A1C below 7? Certainly the result is going to be definitely higher, and you can see that almost 70% could achieve a hemoglobin A1C below 7%. How many had, this is important, because how many could lose the weight? So weight reduction is one of the very important, I think, it's a very lucrative for the physicians to use this drug as a weight reducing pill, and this can reduce the weight up to 5 kg. If you see the levels in the circulation, it is something like what we achieve with the injectable versus oral semaglutide, almost to reach with the same with the 14 mg versus 2.5 mg. So the levels are almost same, but possibly the effect on the hypothalamus, satiety center, and your feeding center may be different with a different load schedule, but overall weight reduction rate, semaglutide is 5 kg as opposed to liraglutide. But remember, the weight reducing dose of liraglutide is not 1.8. From that it has been compared, it is 3 mg. So if you use the 3 mg of liraglutide, then you have weight reduction something around 12 to 15 kg. So half of patients achieve. So how many could achieve a hemoglobin A1C, a weight loss of 5% and a hemoglobin A1C reduction of more than 1%? So around 50% of the patients could achieve both the targets. So meaning by that, so what it concludes that all the patients with semaglutide, those who receive semaglutide, they do not lose weight. The failure rate in liraglutide was something around 30%. Here in the semaglutide, almost again 25 to 30%, they do not lose weight with semaglutide. Why some do not lose? Possibly the sensitivity and the hypothalamus will be responsible for it, but all do not lose weight, but at least 5% and 1% reduction in hemoglobin A1C could be achieved by half of the patients who have used this product. Then change from race. Does any ethnicity? If you have any data for ethnicity, I think the data have already been shown for the DPP4 inhibitors. They are more effective in Asians, possibly because they have a more DPP4 activity. The same thing I think has also been observed in Asian population, that they are slightly better in an Asian ethnicity as opposed to Caucasians. Then a word about the CMEs trial. Any drug which is new in the armamentarium, the management of type 2 diabetes, we should definitely have a cardiovascular outcome, or it should be cardioprotective or neutral. Here you can see that there was a reduction in hemoglobin A1C, there was a reduction in body weight. However, this could not translate into a significant reduction in cardiovascular outcome. It was 21%, but statistically it was not significant. And the reason for that, the power of the study didn't have sufficient power to find out that whether it is really having a beneficial effect on the base or eventually the cardiovascular death. So something required in the study that around 600 deaths which could not happen in that. That's why they are planning for a new study that is called SOUL, and the SOUL will come later. That will really tell us that really the drug has got a beneficial effect. But if we extrapolate from injectable semaglutide to oral semaglutide, the drug and the molecule is same, it is likely to behave in a similar way. However, so far the available data, they are, I will say, more, they are benefit, but it's more towards neutrality. But I mentioned you that observed changes in hemoglobin A1C around 1%, weight loss was around 4.2 kg. But cardiovascular, meaning by that, there must be some hard endpoints at a cardiovascular level which is responsible for decreasing risk. I think the last part is the clinical part, where how to use and what are the concomitant drugs which are administered with the semaglutide and which is mostly taken by the patients with type 2 diabetes. That's why you have difficulties. The first point is that it has to be taken, like very clearly mentioned, that as you get up in the morning, you take a half glass of water. But even you take with less than that, that is more effective. So when you take a more water, the drug gets diluted. So this dilution produces because the availability or absorption of the semaglutide is less than 1%. This becomes further diluted if you take a lot of water. So the advice is only you take a sip of water. You just take a sip of water and ingest the tablet. The second point here is that for how long. You already saw the data of a scintigraphy, where the total erosion of the whole drug was around 57 minutes. So I say at least 1 hour, patient should not take anything. So with a sip of water, rather than even a half glass of water, less than the water, better is the outcome. And it should be minimum 45 minutes. You should wait for 1 hour. I think 57 minutes data, it's a labeled tablet which have been examined, and the total erosion time is 57 seconds. So best is you wait for 1 hour. Then 4 other drugs which are common. I think one is thyroid. The L-thyroxine is taken by almost 30 to 40% of the patients with diabetes. We always used to say that it is a more common association with type 1, but coincidentally, the type 2 diabetes, even our own data from our own institute, in 2,000 patients with type 2 diabetes, almost 30% had a subclinical or overthyroidism. And you also remember that anyone who has got a stage 3 CKD, they were more predisposition to develop a subclinical hypothyroidism and Hashimoto's thyroiditis. So intake of thyroxine is not uncommon with patients with type 2 diabetes. And very surprisingly, there is an increase in area under curve for L-thyroxine if it is taken concurrently. So you have to in fact reduce the doses of L-thyroxine if you take it concurrently. But I think to be very on a safer side, because we also don't know L-thyroxine absorption is usually interfered by most of the substances. Your iron, your calcium, even your B complex, even your pantoprazole. Most of the drugs interfere with the absorption of L-thyroxine. So what I will suggest, I think best is to wait after 1 hour you take your L-thyroxine. Because even if you take concurrently and if AUC for the L-thyroxine is higher, then you have to reduce the dosage, which unnecessarily will lead to the impaired homeostasis at the level of DSH. So you will be frequently playing the dosage and DSH. So best is to avoid that. So I will suggest take 1 hour later. With the anticoagulant warfarin, so frequent IR monitoring is recommended. Here it is not. Then not affected by the commonly administered drugs. I think the most important part was this and thyroxine. Then, yes, another advantage in elderly population, no dose adjustments. Patients with hepatic chronic liver disease, patients with even a CKD also, and all do not require it. What about the patients with GI tract disease? Because usually the drug is preferably absorbed in the stomach. So even someone is having a GI disease, mostly intestine, that may not have relevance. With a hepatic impairment, you don't require anything. Even with a CKD, you don't require, as opposed to liraglutide, you are not supposed to use when the eGFR is below 30 ml per minute. So the safety summary, I think number of people exposed is reasonably good, 5,700 plus, well tolerated. A low rate of severe hypoglycemia, mainly because the drug is acting through GPCR, that is a G protein coupled receptor, rather than the specific sulfonylurea receptors. And why is it glucose dependent insulin secretion? Because the glucose entry is cut off at a blood glucose of 70. So it does not go up. So you don't have a cyclic ALP. That's why it is a very specific. And you also remember that it is not a GLP-1 which is directly stimulating insulin. It is a GLP-1 is potentiating the insulin secretion from the glucose. So it's a glucose potentiating effect of GLP-1 on beta cell rather than a direct effect of a GLP-1 on beta cell. So how do you position? I think everyone will be interested that where you should really position. SGLT2 I think definitely have taken over. So metformin and SGLT2 I think like we have a data from a verified trial which suggests you use even at the hemoglobin A1C of 7. At a 7 you are using a combination of a 2 drug to target the 6 defects of the oblate. Why not we should use an SGLT2 inhibitors that you have enormous data and huge data on cardiovascular and renal protection. So I think the metformin and this SGLT2 they are in call, and I think they are must be the applications. But here again, maximum 3 drugs. And here, if suddenly there is a cardiovascular risk, you will definitely have the edge of this class of drug. So use this class of drug unless the SGLT2 are contraindicated. Or if you have a CKD, even in CKD, the GLP-1 agonistic analogs like liraglutide, you had a beneficial effect on renal function. Only microangiopathic complications which was worsened by lira as well as by SEMA is diabetic retinopathy, which was worsened, however it became stable after some time. But the reason that whenever you do a tight glycemic control, the retinal blood flow is reduced and you may have a worsening of the diabetic retinopathy. Otherwise, the drug is renoprotective, cardioprotective, so even those who are at a high CV risk, I think you can add this class of drug. If SGLT2 are contraindicated, they will go with the metformin plus this class, otherwise metformin, SGLT2 and semaglutide. So what should the practical approach? Treatment, yes, adverse effects. I have a very limited experience that with the oral semaglutide, yes, people are having a nausea and vomiting. Definitely, and you can either continue the same dose of 3 or 7, whatever they are on, but a slightly lower time, and then you can switch to 14 milligram. Encourage to, yes, and if the 20 days pause is already there, then the recommendation is that you re-escalate from lower dose. Suppose someone has developed at 7 milligram, you re-escalate again from 3 milligram. So who is the ideal patients? So I have already summarized that those who are at an appropriate agent for a second line setting after failure of metformin, I think the SGLT2 and this they will compete. So again, we have a lot of data on this that as far as weight reduction, hemoglobin A1C reduction goes more in favor, but certainly the cost improves us. So I will say after metformin and SGLT2 we use this. Weight reduction is definitely superior. If the weight is the main target, we will focus on that. Overall risk of hypoglycemia is very low because of the acting on GPCR. And high risk ASCVD patients, certainly more beneficial, and no adjustments in hepatic or renal dysfunction. And ACE does not appear to affect either safety or efficacy of the oral C. So to summarize, the hemoglobin A1C reduction in oral semaglutide is superior to AMPA and CETA and non-inferior to lira. But you see the weight, superior to CETA, lira and AMPA. However, remember here the lira is 1.8, not 3. The cardiovascular safety, yes, not established with this class of drug. He had a non-significant But if you extrapolate from injectable to oral, it is likely. Overall quite safe and you can use with any comorbidities. So I think with this I conclude my talk. Any question?